Welcome to Guardian CME's integration of stroke severity scales with stroke centers of care, sponsored by Medtronic Neurovascular. This course is designed for all providers seeking to enhance their knowledge of stroke and stroke recognition, but is especially valuable to pre-hospital providers and members of the EMS community. This course will provide 0.5 EMS continuing education credits that are CAPCE accredited for all levels. For more free CME credits, check out guardiancme.com for a full library of courses to enhance your knowledge and complete your required continuing education. This course is brought to you by Medtronic Neurovascular. Medtronic works daily to help thousands of providers and patients fight the battle against stroke. They're passionate, dedicated people who are committed to delivering meaningful innovation to advance stroke treatment, care, and education. To find out more, check out what they're working on at medtronic.com. EMS providers will respond to a significant amount of strokes this year. In fact, every 40 seconds someone experiences a stroke. As a member of EMS, you're called to be an expert on stroke recognition and care. If you need a refresher on the pathophysiology of stroke, you can check out our sister lesson, Foundations of Stroke and Stroke Recognition, also sponsored by Medtronic Neurovascular, right here at Guardian CME. That course will take you through much of the anatomy and physiology of the brain, the areas that stroke affect, and what sort of symptoms a patient would experience as a result, called stroke syndromes. In this course, we'll concentrate more on how applying those principles in the field using stroke identification tools and stroke severity tools allow us to move forward with treatment, both on the way to the hospital and at the hospital. Here are the basics. An EMS provider on the scene of a stroke call will need to first identify that a patient could be having a stroke. This requires a thorough assessment and some prior knowledge of other conditions that can trick us into thinking a stroke is present when it's not. We refer to these as stroke mimics. Once we're confident a patient is likely having a stroke, we need to rate just how severe that stroke is, because depending on the severity, that patient may need to go to a more advanced stroke hospital, depending on your protocols. In the past, this step used to not be the norm. We used to see that the patient had stroke symptoms and then simply transport them to any ER that had access to a CT scanner. The CT scanner would identify if they were having a stroke or not, definitively with imaging, and then the doctors would take it from there. Typically, a patient would get prescribed thrombolytics, that is, medication that would dissolve their blood clot, or they wouldn't if they didn't fit the criteria for those meds, and surgery and prophylactic meds would be prescribed. Now the medical field understands strokes on a deeper level. New assessments can be used to identify the severity of a stroke, and new treatments can remove large clots in the brain. Learning how to assess in these new advanced ways will certainly result in quicker treatments and better outcomes for stroke patients. Welcome to the course. I'm Jason Seitz, and this is Guardian CME. A stroke or brain attack is a sudden interruption in the brain's blood supply. When the blood supply is interrupted, the brain doesn't get the oxygen and nutrients it needs, causing the brain cells to die by the minute. Stroke affects 795,000 Americans each year, is the second leading cause of death and third leading cause of death and disability combined worldwide. Stroke also results in over $72 billion in annual costs. In today's course, we will learn how you can make a difference as a pre-hospital professional in the treatment and identification of stroke and save lives and life quality in the process. In this lesson, you'll learn to appreciate the value of early stroke identification and measurement of severity, compare and contrast stroke screen and stroke severity scales, list and describe EMS treatment considerations for stroke patients, appreciate EMS's responsibility in choosing the correct patient destination, and recognize the importance of collaboration between EMS and stroke centers of care.
The recognition of a stroke differs from the identification of the severity of a stroke, and it's important to see these processes as separate, equally vital parts of your neurological assessment of patients. First, we have to know if a patient is likely having a stroke, stroke screening. Then we can estimate how severe the stroke they are having is, stroke severity. Identification of stroke consists of systematically running through stroke indicators, whilst also eliminating what we call stroke mimics. Stroke mimics exhibit similar signs and symptoms of stroke, but are due to another underlying cause that without the proper knowledge, a provider could mistake for stroke symptoms. When we've ruled out these mimics, our differential diagnosis will indicate the likelihood of a stroke syndrome. Only then will we score the stroke using an approved stroke severity scale. So first, let's start with stroke recognition.
Patients can exhibit a wide array of neurological symptoms when suffering from a stroke. The most common of these neurological symptoms are facial droop, extremity numbness and/or weakness, especially if limited to one side of the body, difficulty speaking or slurred speech, loss of vision, and trouble with maintaining balance and coordination.
These symptoms make logical sense when we consider the brain as the affected organ. Depending on where in the brain the stroke is located, one or more of these symptoms can present. Therefore, as part of our assessment with any patient that shows one or more of these symptoms, EMS providers should conduct a stroke identity scale. Many of these scales exist, and your protocol may or may not dictate which of them to use. In any case, the scale should ensure the discovery of any of the symptoms. For example, weakness on one or both sides of the body can be checked by asking the patient to hold their arms up in the air with their eyes closed for 10 seconds, and then asking the patient to squeeze both of your hands. You'll notice arm drift if the patient has weakness. For lower extremities, the patient can push and pull their feet against the resistance of your hands. Asking a patient to say a word or phrase such as "Mary had a little lamb" can help you identify the presence of slurred speech. Basic mental status questions like person, place, time, and event will help you recognize severe confusion. Asking the patient to smile and show their teeth will uncover the presence of facial droop. And having the patient follow your finger with their eyes can show if the patient is having difficulty seeing in one or both eyes.
If we see that the patient is positive for one or more of these symptoms, we start to suspect that the patient is having a stroke. Now it's time to rule out those pesky stroke mimics to ensure that we don't misdiagnose our issue.
Stroke mimics look just like stroke symptoms, but are caused by other medical or traumatic issues. For instance, seizures are common stroke mimics because they cause altered mental status and periods of unresponsiveness or confusion. The spastic movement of muscles of arms, legs, and loss of coordination could easily be mistaken for weakness on one or both sides of the body caused by a stroke.
To rule out seizures, EMS can inquire about patient history, the time leading up to the incident, and descriptions of the onset of the event. The patient may be experiencing the post-ictal phase after a seizure, and if the patient begins to regain their mental faculties over time, it may be an indicator to consider seizure rather than stroke.
Another common stroke mimic is glycemic emergencies. In some instances, hyper or hypoglycemia can acutely affect the brain's function, resulting in confusion, behavioral changes, slurred speech, and even unconsciousness. The easiest way to rule out a glycemic emergency in the field is simple. Take the patient's blood sugar, along with their other vitals.
Other metabolic conditions can be mistaken for stroke, such as hypernatremia, hyponatremia, uremia, metabolic encephalopathy, and hyperthyroidism. These conditions would be difficult to rule out in the field and require blood or lab work to confirm or deny. In any case, a good EMS provider will do a focused history and physical exam to explore the possibility of stroke mimics while simultaneously confirming stroke symptoms.
Once the index of suspicion for stroke is recognized and common stroke mimics are ruled out, providers should follow up with the use of a stroke severity scale. Stroke severity scales differ from stroke recognition tools in that they quantify symptoms and score them to determine the severity of the condition. The purpose of these scales can help the hospital understand how severe the stroke is, informing your transport decision and giving the receiving facility valuable prep time.
The higher the score, the more likely the patient is suffering from a more severe stroke. Generally speaking, when we say more severe, we mean that there's a higher likelihood of large vessel occlusion. LVOs are common, accounting for about 1/3 of all stroke cases. Ischemic strokes occur when blood supply to part of the brain is interrupted, preventing the brain from getting oxygen and nutrients. Like roadways in a city, vessels branch from larger to smaller pathways, feeding oxygen to brain tissue. A traffic jam on a small side road will certainly have less effect on the city than a larger traffic jam on the main streets. Large vessel occlusions are just this: blockages of the large vessels in our brain that branch into all the smaller vessels, causing major oxygen starvation to massive areas of the brain.
In the hospital, treatment of LVOs can differ from the treatment of smaller blockages. When an LVO is suspected, the patient will need to be assessed for possible mechanical thrombectomy, which is the standard of care in certain patient populations. If the facility is equipped and appropriate doctors are on staff, a thrombectomy can be performed to surgically remove the obstruction.
Some key points to consider when you have a suspected LVO patient are that not every hospital has thrombectomy capability, which may affect where you choose to take the patient. Please be sure to refer to your local EMS guidelines for destination protocols. It's important that we have the ability to recognize LVO during our assessment. Hence, we use stroke severity scales. Our screening is crucial, and by informing a stroke center that we may have a large vessel occlusion stroke, we may save the patient valuable time to treatment, which in turn can save some additional neurons.
Several stroke severity scales exist, including the Rapid Arterial Occlusion Evaluation, or RACE, and the FAST-ED scale. Consult your local protocols for which to use, but stroke severity scales should concentrate on the following information: the last time the patient was seen well, the presence of expressive or receptive aphasia, motor dysfunctions such as paralysis or weakness in one or more limbs, and the presence of agnosia or neglect, which is the inability to interpret certain sensations such as visual, tactile, etc. The three cortical signs of LVO should be included in your assessment: aphasia, agnosia, and gaze deviation. This additional information is then scored based on the scale, and a certain number will be the threshold for suspicion of LVO.
Let's briefly cover why these particular assessments help us recognize the likelihood of LVO. The last time a patient was known to be well is a vital piece of information for a number of reasons. For one, it differentiates the time that the family or other witnesses noticed an onset of symptoms from when the patient was last seen normal. If I went to bed last night appearing normal, and then this morning at breakfast you noticed I was speaking strangely, who's to say that a stroke didn't occur right after I went to bed versus right at breakfast when you noticed my symptoms? The difference between last known well time and time that a witness recognized a symptom can therefore be hours apart. Thinking conservatively, it's important that we choose the time the patient was last seen normal to determine the possible length of time the patient's brain has been ischemic.
Why is the timing so critical? Because both thrombolytics and thrombectomy have time windows in which they are most effective. To meet the criteria for these treatments, the provider will need an accurate window of symptom onset.
The presence of aphasia, or difficulty with speech, is one of the three cortical signs of LVO. Aphasia can be expressive, meaning the patient has difficulty forming speech, or receptive, meaning the patient has difficulty understanding speech. Aphasia usually involves the Broca's or Wernicke's area of the brain, which are fed by large vessels and therefore are an indicator of LVO.
In the same way, agnosia, the inability to recognize objects or people, is a cortical sign of LVO because presentation implies occlusion to the large arteries supplying the occipital, parietal, or temporal lobes. Testing for agnosia can be done by having the patient identify common objects in the room, such as your pen, asking them who a loved one is, or showing them the affected extremity and asking, whose arm or leg is this? Patients affected by agnosia will not be able to recognize that the affected limb belongs to them.
The third cortical sign of LVO is gaze deviation. Gaze deviation can occur in severe large vessel occlusions and typically involves the patient's eye movement towards the affected hemisphere of the brain. In essence, the patient will be looking towards their occlusion while the opposite side of the body will be affected.
With a detailed assessment into these symptoms, we can get an accurate score on a stroke severity scale and recognize the probability of an LVO. Armed with this information, it's time to alert the hospital.
On discovery and confirmation of stroke symptoms, the EMS provider's mindset needs to switch into a high priority mode and recognize that time is brain. Every second counts in our goal to restore perfusion to brain tissue, and salvageable tissue will quickly die without prompt intervention.
Per your protocols, when contacting the appropriate facility, ensure that before giving your report on initial contact while identifying your unit's name and the call priority, state that you're calling with a stroke alert.
Immediately activating a stroke alert does a number of things. The hospital will clear a CT room and prepare for a stat CT scan. An ER physician and the care team will prepare for a neurological assessment upon your arrival. Thrombolytics can be prepped, and if your patient has a high severity score resulting in suspicion of LVO, neurointerventional radiology labs can begin to prepare for possible thrombectomy. With your early activation, you've given the emergency room time to prepare for these processes and save the patient valuable time.
After identifying yourself and activating a stroke alert, you will continue to give a report as normal, ensuring your destination facility receives the patient's last known well time, the type of severity scale and score you have obtained, the patient's vitals and presentation, and other pertinent information. With the facility notified and prepared, and you and your team on the way, you can continue treatment knowing you have optimized the patient's time.
After identifying stroke symptoms, ruling out stroke mimics, scoring its severity, determining last known well time, gathering a list of patients' medications, and alerting the hospital, treatment for strokes in the field is quite simple. Since time is so critical, no procedures that would delay transport time should be conducted on scene. For example, If an IV was not established while vital signs and assessment were being done, it should be performed en route to the hospital to shorten scene time. The same goes for EKG tracing. Time is critical, and any treatment that can be done on the move should be.
With that said, treatment for stroke is fairly straightforward. First, stroke patients should be cared for with compassion and empathy. Stroke patients can be confused, distressing them further. And simply talking to your patient through the processes that they're experiencing and helping them decrease their anxiety level can help subsequently decrease their oxygen demand, as well as provide comfort in a time of crisis. Just because the patient may not be able to communicate does not necessarily mean they do not understand what is happening, and comfort goes a long way.
As with all patients, first identify life threats with an ABCDE assessment. Any compromise to airway patency should be corrected immediately. Breathing should be controlled if irregular or absent, and circulation should be assessed via pulse checks and skin signs. Vital signs should be attained and monitored, including blood pressure, oxygenation, pulse rate, EKG interpretation, breathing rate and rhythm, and blood glucose check. Remember, blood glucose readings are important for ruling out common stroke mimic of hyper or hypoglycemia. Oxygen administration should be done on any patient experiencing low oxygen levels. Titrate oxygen levels between 94 and 99%. IV access should be attained, but avoid giving dextrose-containing fluids, such as D5W, unless the patient is hypoglycemic, and avoid giving large amounts of fluid of any kind. Once transporting, a baseline 12-lead EKG should be obtained. Remember, do not delay transport, as time is critical.
As EMS providers, it can be a habit to learn what happens only up to the point where the patient is no longer under your direct care and you've dropped them off at the hospital, then simply moving on to the next demanding case. But we want to encourage you to better understand what the providers at the hospital will be doing. Not only does this broaden your knowledge as a provider, but it also ensures you understand the significance of why you perform the actions you do in the field and how they affect the patient and how you are a part of a much greater whole.
EMS is a crucial part of an interdisciplinary team, and understanding what the team is accomplishing together encourages providers to think deeper about what they're doing in the field and how it can improve outcomes down the line. It also prevents mistakes and misunderstandings and promotes positive communication and relations between first responders and hospital providers. So let's talk a bit about what the hospital will do after your involvement.
First and foremost, the emergency department staff will ensure that the patient is stable for transport. They will also perform a neuroassessment. Once deemed stable for transport, the patient will then be transferred to have a CT scan performed. CT is short for computerized tomography scan and is sometimes referred to as a CAT scan. The first CT scan will be performed without contrast. This is to rule out bleeding in the brain. Once it's confirmed that the patient does not have bleeding within the brain, a CTA, or computerized tomography angiography, can be performed. This imaging procedure includes the injection of contrast dye, which helps the physicians identify clot location. Lastly, if indicated, the patient can also have a CTP performed. A CTP is a computerized tomography perfusion study that can help physicians further identify areas of the brain that are at risk for ischemic injury.
Utilization of best practices after identification of stroke activation and stroke alert is for EMS providers to be cleared to take the patient right to CT. This can only be accomplished through clear communication with the hospital and the hospital readiness while the patient is being transported. Hospital stroke teams should clear a CT room and be prepared for EMS arrival. On arrival, EMS should move the patient right into the CT room where providers can quickly get imaging taken care of, saving precious time.
Once performed, skilled providers will view the scan and determine whether or not the stroke is ischemic or hemorrhagic. Basically, are the symptoms from a blockage in the vessels or from a ruptured vessel causing internal bleeding in the brain? Utilizing a CTP, they'll determine the significance of the damage to the brain and identify any salvageable tissue. Finally, they'll determine a treatment.
There are two types of strokes a patient can have: hemorrhagic or acute ischemic. Hemorrhagic stroke, sometimes referred to as a spontaneous brain bleed, occurs when a weakened blood vessel ruptures and bleeds into the surrounding brain tissue or subarachnoid space. Hemorrhagic strokes make up about 13% of all strokes. Acute ischemic stroke occurs when a vessel supplying blood to the brain is blocked. Ischemic strokes account for about 87% of all strokes.
Hemorrhagic strokes are devastating medical emergencies that are difficult to treat emergently. Treatment for these is largely supportive in the first 24 hours or until the bleeding is stable, but might also include the insertion of a drain known as a ventriculostomy to release the pressure. Depending on the cause of the hemorrhagic stroke, additional procedures may be performed during the hospital stay. A crucial intervention for these patients is strict blood pressure control, which can decrease the risk of the expansion of the hematoma.
If the patient is on blood thinners, this can contribute to the bleeding within the brain. To reverse these coagulopathies, the physicians must know which blood thinner the patient's on. This is a crucial piece of information to gather from the patient or patient's family, if at all possible. Certain anticoagulants have reversal agents that can be given to the patient to reverse the medication's effect. If the anticoagulant does not have a reversal agent, then the patient can receive fresh frozen plasma to help with the clotting cascade.
More invasive measures include various surgical procedures. Removing blood from the brain can help relieve pressure. If accessible, blood vessels can be repaired in brain surgery. To reduce the risk of rebleed, surgical clipping involves placing a small clamp onto the base of an aneurysm to essentially micro-tourniquet the bleed. Coiling involves feeding a catheter up into the brain from the femoral or radial artery, and to fill the aneurysm with soft coils to stop the blood from flowing into the aneurysm.
Ischemic strokes are a whole other story and have the potential for a much better outcome. After CT identification, hospital providers will know where the blockage exists in which vessel and have several options available for treatment. The treatment goal in an ischemic stroke is to restore blood flow. There are several treatment options such as IV thrombolytics or surgical intervention.
If the ischemic stroke has occurred relatively recently, usually within 4.5 hours, the patient is a candidate for thrombolytics. Thrombolytic agents are administered intravenously to dissolve blood clots and improve blood flow to the brain. As we mentioned before, it is extremely important for EMS to identify the patient's last known well time, so hospital providers can determine if the patient is a candidate for these meds.
In large vessel occlusions, it's possible to remove the clot altogether. This is called a mechanical thrombectomy. Mechanical thrombectomy is a minimally invasive surgical procedure that uses a small stent retriever and/or an aspiration catheter to remove blood clots in the brain.
In order for these procedures to be attempted, providers need to know if the clot is in a large vessel and prepare for surgery. Again, this is why scoring a stroke on the severity scale while still in the field can make a significant impact on the hospital's readiness to deliver definitive care.
Knowing the capabilities of your hospital destination is important, but it's worth stressing this point. Your protocols will dictate which hospital you transport to more often than not. For instance, at the time of this video, my own transporting ALS municipality currently states that if there are any signs of stroke, LVO or not, the patient should be taken to the nearest CT-capable stroke center, not necessarily the best stroke center for the job, like a thrombectomy-capable center, in the case for evidence for LVOs. However, the same municipality is running studies to collect data to possibly change these protocols to be more patient-specific after advanced assessment. This is important because the education you're taking part in is beginning to change what we do in the field, but it may not have caught up to your current protocols, and you'll need to ensure you follow the parameters set for you first and foremost.
So, as we learn about stroke centers and their capabilities, it's useful knowledge that can help you make informed transport decisions depending on your patient's presentation. But keep in mind your local protocols may supersede your opinion based on field discovery, and it will require communication with the hospitals and your medical directors to make changes.
Stroke centers are divided into 4 classifications: acute stroke-ready hospitals, primary stroke centers, thrombectomy-capable stroke centers, and comprehensive stroke centers. These centers are given their designation through the Stroke Center Certification Program, which was created in collaboration between the Joint Commission, the American Heart Association, and the American Stroke Association. Each of these facilities have slightly different capabilities when it comes to the treatment of stroke.
Acute stroke-ready hospitals must have a dedicated stroke-focused program, provide basic assessment and triage of stroke, and provide basic treatments. ASRHs are the lowest level of skill required to be considered a stroke center.
Primary stroke centers will have an acute stroke team on staff, as well as dedicated patient beds for stroke patients in the ICU. They'll provide CT scanning, thrombolytics, and emergent care, and may rely on transport to more advanced centers for longer-term care or thrombectomy.
Thrombectomy-capable stroke centers are what they sound like: stroke centers capable of providing thrombectomies to patients with large vessel occlusion, as well as the treatments and assessments required of lower designation stroke centers.
A comprehensive stroke center is the highest level stroke designation that can be achieved. In addition to providing the same services and staff as the other 3, comprehensive stroke centers have staff that are trained in specialty areas such as vascular neurology, neurosurgery, and endovascular procedures that are required to be working or on call at any time. More advanced imaging is also required beyond CT scanning. These centers can handle more complicated stroke patients with LVOs and severe hemorrhage.
Having an understanding of what stroke centers are available to you for transport helps you play your essential role in the stroke chain of survival. With the knowledge of the presence and severity of stroke, the hospital treatments available to your patient, and the stroke centers of care capabilities, you can make an informed transport decision guided by your protocols to get your patient the fastest and best care possible.
So you've responded to an emergency, effectively assessed and identified a stroke, scored it on a severity scale, activated a stroke alert, and communicated with the correct stroke center of care. They prepared the necessary teams and equipment while you transported, and on arrival, you hand the patient off into the CT room. Your job's gotta be done now, right?
Unfortunately, not quite yet. In fact, some of the most influential work in stroke takes place following the emergency. It may not be glamorous, but it's important nonetheless. We're talking about paperwork. Proper documentation after a stroke emergency works in a number of ways to influence positive change in the future of stroke care.
You may have heard the phrase, if it's not documented, it didn't happen. Properly documenting the good, the bad, and the ugly of your stroke calls helps data to be gathered to improve outcomes moving forward. Charting is immensely important to collect the right data to then research in a stroke system of care. We can't improve if we don't know what's happening.
In addition to your normal narrative and patient data, stroke call records should reflect a few additional things. If and when a stroke alert was activated, which stroke severity tool was used, what the score was, a description of the symptoms present, whether LVO criteria existed within the scale, how the hospital was chosen and communicated with, and the process of the patient handoff. The hospital will record additional data, including the patient's outcome, and your stroke system of care should have a way to integrate these two reports to reflect key data for quality improvement. A QA/QI process should be established that allows a trained professional to review cases and collect additional data and recommend training or system improvements.
Okay, so I've charted this call now, and it's been viewed by quality improvement. Can I please stop thinking about stroke for a bit now?
Nope. So now we have to train. Training is an essential part of the process. An advanced identification of stroke through scoring tools is still a relatively new EMS initiative. To make it work, we'll need to train regularly and achieve buy-in from EMS agencies and stroke centers alike.
EMS agencies should be trained with educational offerings like this one to understand the general concept of integrating stroke severity scales systematically. They should also participate in protocol-specific training and how their agency will uniquely integrate a stroke system of care. Providers should be taught each step of the process, even the ones they aren't involved in, to have a solid foundation of knowledge on how the parts will become a whole. Finally, they should train with their local stroke centers on how they will communicate during an incident, what will be communicated, and how they can streamline the patient transfer process.
Hospital staff will need to train on how they will receive reports on stroke findings and understand what processes to begin once those findings are interpreted. Again, interdisciplinary training involving EMS will improve the team's ability to communicate well and deliver systemic care.
Integrating stroke severity scales with stroke centers of care to build an entire stroke system of care may seem quite daunting, but keep in mind that your participation in this course is a large part of starting. With proper education and identification of needs, you take the first step into building or improving your current system. When it comes down to it, simple, small changes like using stroke severity scales and communicating more effectively with the hospital can make large impacts on the system, the community, and your patient. We hope you've enjoyed this lesson and can now recognize the significance of the work you do towards improving stroke outcomes in the field. In review, you've learned to appreciate the value of early stroke identification and measurement of severity. Compare and contrast stroke screen and stroke severity scales. List and describe EMS treatment considerations for stroke patients. Appreciate EMS's responsibility in choosing the correct patient destination. And recognizing the importance of collaboration between EMS and stroke centers of care. To receive your credit, make sure you complete the post-course quiz and evaluation. This concludes Guardian's lesson on integration of stroke severity scales and stroke centers of care, sponsored by Medtronic Neurovascular. We want to thank Medtronic for the opportunity to bring you this educational offering and for championing education for EMS providers. If you've enjoyed the lesson, feel free to leave feedback when prompted. And check out our sister lesson, Foundations of Stroke and Stroke Recognition, also sponsored by Medtronic Neurovascular, to learn more about how else you can make a difference in pre-hospital stroke care. Finally, we want to thank you, the viewer, for taking the time to learn these valuable lessons. We at Guardian believe that lifelong learning is the mark of a true professional, and that by participating in continuing education, you work to grow the EMS community and help those in need. Keep up the good work, keep learning, and be safe. Thank you for what you do. We'll see you next time.